Okay, it's time to begin. So I'm going to call this meeting to order. If you're able, please join me and stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you very much. Roll call, please, Dee.
Director Yee.
Present.
Director Stewart.
Present.
Director Wallace. Director Epen.
Present.
Director Nicholson.
Present.
Very good. And who's there in the room with you?
In the room, we have Kimberly Hartz, Ed Fayen, Chris Henry, Shri Bodu, and me, D'Antonio.
Great, thank you. Nice to see you. Safe and sound, Ed. Well, welcome to the October 12, 2022 regular meeting of the Washington Township Healthcare District Board of Directors. To continue to protect the health and safety of the members of the board, district staff, and members of the public from the dangers posed by the SARS-CoV-2 virus, the Brown Act allows a local agency to continue to hold its meetings remotely as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Healthcare Services Public Health Department COVID-19 website at www.covid-19.acgov.org. I ask for a motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
Madam President, I make the motion that the board make the finding required by section 54953E3BII of the Government Code that state and local officials continue to impose or recommend measures to promote social distancing.
Thank you. Is there a second?
Second.
Thank you very much. Roll call, please.
Director Yee.
Aye.
Director Stewart.
Aye.
Director Wallace. Director Epen.
Aye.
Director Nicholson.
Aye.
Very good. Thank you. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Moving on to communications, members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Are there any written communications, Steve?
No, there are not.
All right, then we will move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under action item heading of the agenda. Does anyone on the board want to remove an item from the consent calendar? Hearing none, then may I have a motion to approve the consent calendar items A through E?
I move that the Board of Directors approve the consent calendar items A through E.
Thank you very much. Is there a second?
Second.
Thank you. Roll call, please.
Director Yee.
Aye.
Director Stewart.
Aye.
Director Wallace. Director Epen.
Aye.
Director Nicholson.
Aye.
Very good. Thank you. All right, now the fun part. We have some presentations. Kimberly, I'll give you the honor of introducing our first presenter, please.
Okay, thank you very much. It is my pleasure to introduce Dr. Carlton Sharman. He's a hematologist oncologist who joined UCSF Washington Cancer Center in 2021 and cares for patients with a wide variety of cancers and blood-related conditions. He has a particular interest in caring for patients with lung cancer. Dr. Sharman earned his medical degree from the University of California, Davis School of Medicine. He completed a residency in internal medicine at Oregon Health and Science University, and he completed a fellowship in hematology and oncology at Tufts Medical Center, where he participated in international collaborative research on Hodgkin's lymphoma. So it's my pleasure to introduce Dr. Carlton.
Great, thank you so much for that introduction. I'm going to go ahead and share my screen here. Can you all hear me, by the way?
Yes.
Great,
Yeah.
wonderful. So I'm going to share my screen. Give me 1 second here. Get started. Okay. Okay, very good. Can you all see that?
Yes.
Yes.
Okay, wonderful.
can.
So again, thank you so much for the very thoughtful introduction. Again, for those of you who haven't had the pleasure of meeting, my name is Carlton Sharman. I'm one of the medical oncologists here at UCSF Washington Cancer Center, which I had the honor of joining in September of 2021, and has really been such an incredible and rewarding experience over the past 13 months since I've been here. Now, what I'll be talking about today for the next 20 or so minutes is about some of the novel non-chemotherapeutics that are being used for the treatment of cancer in the modern era. You know, one of the aspects of oncology that really drew me to this field is the rapid innovation and the evolution that really changes how we treat patients every year, every 2 years, in a very quick rate. And while chemotherapy is something that we certainly have all heard about and have some knowledge about, there are so many exciting new classes of drugs that are being used that are based on just incredibly innovative science that I'd love to share with you some of that today. So first, what I'd like to do, just looking at an agenda for the next 15, 20 minutes, is first I'd like to just spend a few minutes talking about the UCSF Washington Cancer Center and the partnership that we have with UCSF and what that essentially entails. Then we'll move into the meat of the talk, first talking about the pros and cons of chemotherapy, and then we'll talk about some kind of more prominent examples of novel therapies, one of which are called targeted therapies, also antibody drug conjugates, immunotherapy, and then finally genetically engineered immune cells. And so again, just to spend a few minutes about the UCSF Washington Cancer Center and the inherent partnership between the Washington Hospital Healthcare System and UCSF that I think really benefits patients and providers, both in the Tri-Cities communities, but also I think in San Francisco as well. Now, when it comes to the benefits from a Washington hospital perspective, strictly from a medical and resource perspective, one of the main benefits is access to clinical expertise. And so, we have the ability to consult experts across all subspecialties of hematology and oncology, whether it's breast cancer, lung cancer, GI cancers, leukemias, lymphomas, you name it. And so we have the ability not just to refer patients to them, but we also have a lot of these experts, these world-renowned experts in the field on speed dial. We can call them, we can text them, we can email them, and we were able to get just essentially world-class expertise at our fingertips. We can then bring to our patients' care here in Fremont, which really does, I think, have a huge impact on patient care for many of our patients. Additionally, access to clinical trials is a huge, huge aspect of this partnership. Clinical trials are generally run in major medical centers, academic medical centers, and for patients out in community centers that are outside of those main hubs, is that a lot of these patients are under-recruited for clinical trials, which really eliminates a huge aspect of therapies that patients could be taking part in as part of the treatment course. And so not only do we have access to all of the clinical trials at UCSF that across all hematology and oncology that people can be sent to San Francisco to enroll in, but additionally, we also have multiple trials that we also serve as a local site for enrollment here in Fremont. And so that allows patients to be a part of research endeavors and clinical trials here in their own community. And then also expedited referrals. So as you can imagine, a lot of cancer diagnosis and treatment is often very time sensitive. And so because of the many avenues of communication, avenues of coordination that we have with UCSF, we're often able to get patients in to be seen by our expert colleagues on a fairly quick time frame oftentimes, which I think, again, also can essentially, save patients' lives sometimes, getting things done quicker, and essentially hopefully improve outcomes as well. Now, how does UCSF essentially benefit from this partnership? Well, number one, we are a major source of clinical trial recruitment, as one of their clinical sites in the community. And so we certainly represent a large, group of patients who essentially can be sources for patients for their clinical trials. UCSF, again, is a major academic research institution. And so it's in their best interest as well to try to recruit patients for clinical trials to help answer the clinical questions they're trying to answer. And so we certainly serve as a robust resource for that. Additionally, similarly, we also are a more wide-reaching referral base for referrals to send over to UCSF as well. And then also, there are a lot of patients who never necessarily establish care in our clinic, but are seen in San Francisco at UCSF to have potentially, very complex care needs that they have up there. And ultimately, once those complex care needs are no longer an issue, they then can be transitioned to maybe follow up in their local communities, potentially, at UCSF Washington Cancer Center. And because of our avenues of communication, we're able to essentially, in coordination, able to have a smooth transition, a smooth handoff, and still actually have coordination of care with San Francisco at UCSF as well. And then obviously there's also this constant ongoing engagement between ourselves and with our colleagues in San Francisco for the purposes of always trying to grow the cancer center and better optimize the ways we can serve our communities here in the Tri-Cities areas. And so just to illustrate some examples as well about some of these concepts. So just an example of a patient that I've been following over the past several months is a 33-year-old pregnant woman who unfortunately was diagnosed recently with a stage 4 breast cancer. And she also was found to have a mass concurrently that was compressing her spinal cord, for which she was very symptomatic from. And so when I saw this patient in clinic, I was very, very worried about her. And so I immediately called one of our expert breast cancer colleagues in San Francisco at UCSF, who was equally as concerned about this patient. And she ultimately immediately got on the phone to speak with one of the neurosurgeons at UCSF. And within record time, this patient was referred to San Francisco, and within hours was in the operating room in San Francisco having the surgery done. And so that was just something that I'd never really seen before, really in my fellowship or training or anywhere else. And then to have such an immediate care was really mind-blowing to me. And you can imagine that coordinating care for someone like this would be incredibly challenging with the surgical needs for her complex spine surgery, the surgical needs for breast cancer, the chemotherapy treatment, and obviously also managing her high-risk pregnancy. But because of our partnership with UCSF, all parties were able to collaborate effectively for her case, such that she could receive some of her care in San Francisco, some of her care in Fremont, in a way that was done relatively seamlessly, despite the high complexity of her needs. And I don't think this would have been possible without our partnership with San Francisco, with UCSF. And so I think this really demonstrates the access to expertise and the expedited referrals that I think can have a very meaningful impact on patient care. And just another example from a research perspective, I also recently had been taking care of a 55-year-old woman with a newly diagnosed stage 1 breast cancer. And as many of these patients receive, she had surgery as kind of the first part of her care. But then typically the next step in that situation is to receive radiation. And UCSF actually has a clinical trial looking to see if radiation can be omitted in certain patients. But when we discussed this with the patient, she said, I can't go to San Francisco. I can't get to San Francisco to be in a clinical trial. But ultimately, we became an actual enrollment site for this study. And so this patient was able to enroll here at UCSF Washington Cancer Center and be a part of this study without having to essentially leave her community, which I think, again, is a very useful benefit for our patients here in the Tri-Cities areas. So now let's move into the other part of our talk. Let's first talk about chemotherapy. Now, when it comes to chemotherapy, there's no true one definition for what chemotherapy is, but I like to describe chemo as medicines that essentially target rapidly growing cells, like cancer cells, for example, thereby essentially acting like poison to cancer cells. And some of the benefits of chemotherapy are that, number one, they work quickly. They also work powerfully, so it can really shrink cancers down very effectively. And also, they've been around for a long, long time. And so we have lots of good data on effectiveness, lots of good data on safety. And so when we're counseling patients, we can be very thorough in describing how chemotherapy works and what to expect, both in the short term and in the long term. However, rapidly dividing cells in our body are not just limited to cancer cells. There are tons of normal cells in our bodies that tend to divide rapidly. And because of this, they're potentially susceptible to the effects of chemotherapy. For example, hair rapidly divides. And so if chemotherapy affects that, there can be hair loss. If the stomach and the gut are affected, it can lead to nausea, vomiting, and diarrhea. If the mouth is affected, it can lead to mouth ulcers and altered taste. If the skin is impacted, it can lead to rash and dry skin. If the nails, which also rapidly divide, there can be nail discoloration and brittle nails. And our blood cells are also rapidly dividing cells. And so if those are affected, it can lead to fatigue, infection, and also increased risk for bleeding. And so again, really one of the major downsides to chemotherapy is that there are lots of rapidly dividing cells in our bodies that are normal and non-cancerous. And they can be essentially these innocent bystanders to the effect of chemotherapy, which can manifest as prominent side effects. So to use some analogies here, when we think of chemotherapy, we might think of chemotherapy more almost like a dirty bomb, so to speak. And that, again, there are some of these innocent bystanders in our normal cells, and that they affect, again, non-specifically, rapidly dividing cells that impact both cancer cells and normal cells, and therefore can translate to more side effects. In contrast to that, we have now a whole class of medicines called targeted therapies. And targeted therapies are very specific, actually. They are very specific in contrast to chemotherapy, in that they target a very specific protein, typically in a cancer cell. And because of that, because these are preferentially impacting cancer cells rather than normal cells, they tend to have far fewer side effects. And so, again, if we were to think about chemotherapy more like this kind of dirty bomb, so to speak, we might think of targeted therapy as a much more precise weapon, more like a rifle or something like that, where they essentially can try to eliminate a cancer cell without harming normal cells as much. And so again, these types of medicines really change the game when it comes to our current cancer therapies. Now, a classic targeted therapy that we use is something called trastuzumab or Herceptin. Many of you in this room may have heard of this medicine, but it's a medicine we've used for many years to treat breast cancer. Now, how does trastuzumab work? Well, if you look at a normal breast cancer cell, you look at the outside of the breast cancer cell, which is kind of this pink kind of ring here. Normally, there are some proteins, which are shown in purple here, called HER2 proteins. And the function of HER2 proteins are to essentially stimulate the cancer cell to grow. Kind of sends a signal to the core of the cell called the nucleus, which is the brain of the cell, to tell it to grow and divide. Now, there are certain types of breast cancers called HER2 positive breast cancers, where instead of having just a couple of these HER2 proteins, it's just jam-packed with these HER2 proteins. So instead of getting a few of these signals to grow and divide, it's just getting all of these signals to grow and divide, that it just inundates the cell. And it starts to just grow and grow and grow in this unregulated fashion to the point where it starts to develop tumors and more widespread cancers in patients. So what does trastuzumab, also called Herceptin, what does it do? How does it actually work? Well, trastuzumab is essentially a targeted therapy that targets HER2. And so when you give it to a patient, essentially what happens is that it will bind to the outside of the cell and bind to the HER2 proteins and essentially blocks that activation signal that HER2 is trying to send to the nucleus of the cell. And so it limits it from growing. So that's one of its main effects, that it stops the growth of cancer cells. And then additionally, by binding to the outside of the cell, it also kind of acts like this kind of red waving flag to the immune system saying, hey, we got a cancer cell over here. And it kind of recruits the immune system to then come in and try to kill the cancer cell. And so that's really how trastuzumab works in this very elegant way. Now, it's important to note that essentially trastuzumab does not actually directly kill cancer cells. It essentially, again, it limits the growth and it also brings in the immune system to kill the cancer cell, but it doesn't actually directly kill the cancer cell, so to speak. And so the question becomes, is there a way that we can modify targeted therapies like trastuzumab so that they can directly kill cancer cells? And could that potentially be even more effective in treating these cancers? And the answer is yes. And that is what we see with what are called antibody drug conjugates, as shown here on this slide, which essentially combine targeted therapies like trastuzumab with chemotherapy to form these much more innovative structures. And to, again, use an example of trastuzumab, I'll describe that here. And so trastuzumab, again, is a targeted therapy, and it's considered what's called an antibody, which is an immune system protein, and that's the antibody part of antibody drug conjugate. And it can be combined with a drug called DM1, which is a molecule of chemotherapy, to form a medicine called TDM1. And this is a medicine we now use regularly for HER2 positive breast cancer, as I described in the last slide. Now here is what TDM1 looks like. It's essentially trastuzumab, which is this kind of purple, kind of Y-shaped structure here, as you saw in the last slide as well. But instead of just being trastuzumab, essentially it's also linked to molecules of chemotherapy, these kind of yellow stars that you see here in this figure. And so these two things together form TDM1. It's just essentially trastuzumab linked to a few molecules of chemotherapy, in contrast to this trastuzumab by itself. And so what happens when you give this to a patient? So essentially, when you give this to a patient, this complex of TDM1 will then bind to the outside of the cancer cell and bind to HER2. And then essentially that whole complex then gets internalized into the cancer cell, as you see there. And then once it gets internalized, essentially the inner machinery of the cancer cell will then go in and try to break all of that up. Just basically breaks up the trastuzumab and the TDM1, and essentially liberates those molecules of chemotherapy that they can then go off and cause all this rampant destruction in the cancer cell, and essentially then leads to cell death. And so it's just this very elegant and very amazingly innovative way of augmenting and converting targeted therapy into something a little bit more powerful and delivering more dangerous weapons to kill cancer cells, essentially. And so that's what these antibody drug conjugates do. So let's talk about immunotherapy next. And so as a background, while we think of our immune system as obviously being very important in fighting off infections like viruses and bacteria, the immune system is also very, very important in constantly surveilling for mutated cells and cancer cells and trying to eliminate them before they can grow and grow and grow to become a tumor or more widespread cancer. And this clip here I'm about to play essentially shows that. And in purple here is a white blood cell, which is an immune system cell. And it's basically trying to fight off this monstrous looking green ovarian cancer cell. And as you can see here, when the white blood cell binds to it, it essentially releases some of those kind of pink flashes of chemicals that then essentially cause that cancer cell to shrivel up and die. And so that is constantly happening in our bodies all the time, fighting off these cancer cells. And so you might be asking yourself, well, if this is happening, how do tumors develop? How do widespread cancers develop? Well, the answer is because cancer cells are very sneaky. And essentially what they can do is they can start to make certain proteins that make themselves invisible to the immune system. And so kind of like Harry Potter, if any of you are Harry Potter fans, Harry Potter had this invisibility cloak. And when he wore it, he could essentially hide from his enemies and can do things to fulfill his mission. And that's essentially what cancer cells do. They kind of can don an invisibility cloak and hide themselves to the immune system so that they can grow and grow and grow in this undetected way and form more problematic cancers for patients. And so immunotherapy essentially tries to reverse all that. It essentially tries to harness the power of the immune system and tries to make these invisible cancer cells visible to the immune system again. And so again, in more of a schematic form here, again, when tumor cells bind in a certain way to certain white blood cells of the immune system, in this case, a T cell, it essentially can deactivate those white blood cells and essentially make the cancer cell essentially invisible. So it can grow and grow and grow and start to cause problems for a patient. What immune therapy does, it essentially blocks that inhibitory interaction. So the tumor cell can't turn off that white blood cell. So it's inherently remaining activated and inherently continuously surveilling and activated and trying to essentially kill tumor cells in this more very aggressive way. So that's what immunotherapy is essentially doing. And so what we see is that instead of having just one white blood cell, for example, killing a cancer cell, if you were to look inside a patient, you might see this, where there are all of these many white blood cells going after cancer cells in a much more aggressive way, and essentially leading to much more widespread cancer cell destruction. And so immunotherapy, again, is a totally different modality of treating patients. And this is a totally new paradigm of therapies that we now incorporate to many different types of cancer treatments, and has really, again, changed the game when it comes to cancer treatment for patients. Now, the final category of medicines I'll talk about for a minute or two are called CAR T cells. And this I really find to be just a mind-blowing scientific experiment that has essentially changed how we treat certain types of cancer patients, particularly with blood cancers. And CAR T cells are essentially genetically modified immune cells, and they combine aspects of immunotherapy and targeted therapy. And so how does this all work? Well, if you have a sick patient who is sick with, let's say, leukemia or lymphoma, and they've run out of therapeutic options, then the first step in this process is to essentially hook them up to basically a big IV and try to extract out some of their white blood cells from their blood. Those cells are then sent off to a very specialized laboratory. And what is first done is that those cells are isolated, and you try to extract out what are called the T cells. And the T cells, again, are the white blood cells in our immune system that are the most kind of anti-cancer fighting immune cells that we have in our bodies. And then the amazing part is that those T cells are then taken and then they're genetically modified so that they are reprogrammed essentially to specifically fight specific kinds of cancer cells. And so if this patient, for example, had lymphoma, then these T cells are inherently programmed to fight lymphoma cells, targeting a very specific protein that is found preferentially on lymphoma cells. So that these T cells are now, they don't care about viruses as much, they don't care about bacteria. All they want to do is find lymphoma cells and kill them. And so once this happens, they ultimately then grow and expand these T cells in the lab to get lots of them. And once they're ready to go and they have enough of them, they send them back to the hospital where the patient is, and they essentially give them to the patient. So then what happens next? So you give them to the patient. Now these yellow cells here, these activated CAR T cells, which are primed to kill lymphoma cells, then find these lymphoma cells, they get activated, they kill them off, and they make more copies of themselves as they get activated. And they essentially can lead to very widespread destruction of lymphoma cells, as in this patient example. And so these are typically, again, given for patients who fail all these different other treatments, and this might be their only option. And we've seen cases where patients who fail everything else and they get this therapy can have complete resolution of their cancer in this incredible way. And this type of medicine is kind of called what's called a living drug, because it's not a medicine you're giving somebody, you're giving them actually cells. These are live cells, and they're living because they can live for a long time. They can make more copies of themselves such that the response the patient can have can last for a long, long, long time. And so I just find this type of treatment to be incredibly innovative and incredibly interesting. And so just to wrap things up here, some take-home points again. Chemotherapy, while we use it very often now still in oncology, one of the inherent issues with it is its lack of specificity, in that it just targets non-specifically rapidly dividing cells, and as such can affect some of our normal rapidly dividing cells, thereby leading to more side effects. Whereas novel therapies, they are much more specific, and they target very specific proteins, very specific aspects of cancer cells that are preferentially seen in cancer cells more than normal cells, thereby often being better tolerated compared to chemotherapy. Also, as I mentioned in detail, the immune system is being harnessed in a variety of ways to combat cancer, both with immunotherapy and also with CAR T cell therapy. And then also, this is just the beginning. You know, new therapeutic targets are being identified at an explosive rate, and many drugs with new targets are being introduced to the pipeline on a yearly basis. And so the future of oncology I find to be very bright, very exciting, and I really can't wait to see what the future holds for our patients. And so on that note, I'd like to thank you all again for your time and attention, and I am open to any questions or comments. Thank you.
Thank you, Dr. Sharman. I speaking for myself, I appreciate your enthusiasm and the hope that I hear in your voice that cancer is not the death sentence that it once was. And you mentioned innovative science, and that just that it brings that state-of-the-art treatment option to our residents. And just having this partnership with UCSF is a win-win for everybody. And I appreciate what you've shared tonight. It's very exciting. Thank you.
Of course, yeah, and I truly agree with that. You know, I've been here for 13 months now, and it really has changed, and the way that I view how patient care can be. You know, for patients not just in major academic centers, but all over other parts of the region. And so it certainly has changed the way I treat my patients, and it's certainly, I think, changed the course of their care in many ways. And so it is
Oh,
an extraordinarily
absolutely.
beneficial partnership. Yeah.
Absolutely. Any questions for Dr. Sharman from the other board members?
Well, I have a comment and then a question. Well, first of all, I'd like to thank Dr. Sharman for his excellent presentation, but more importantly, I'd like to thank him for his excellent clinical care that he's given to our patients over the last over this last year. So my question is, has to do with how long does it take for one of these novel therapies to come to market, from the proof of concept to the point where is it FDA approved? And the corollary to that question is, what is the advantage of having accessibility to clinical trials to provide patients at Washington with availability to these novel drugs or novel therapeutics prior to FDA approval?
Yeah, so great question. So for the first question about the time to market, that can take a long time. So it can take years from proof of concept, and that happens, years in prior to the drug coming to market, because first of all, you have to essentially do basic science studies to try to identify in the laboratory about specific targets that are fundamentally critical to the survival of the cancer cell. You can identify maybe a protein that exists in a cancer cell, but it may very well have no significance to the survival of the cancer cell. So that targeting with the medicine actually does nothing, right? And so identifying a target and then essentially going through at that point, animal studies, for example, in vitro studies in a lab, and then doing, early phase studies, we're looking at safety, and then moving up to a phase 3 study. That is often years. That could be 5-10 years from proof of concept to actually getting into the FDA for approval. And there are certain examples where studies are happening that are earlier on. It hasn't gone through the whole process, but there may be some earlier stage studies that are promising. And because maybe in a certain cancer, there are very, very few options for treatment, that the FDA will actually grant what's called accelerated approval, meaning that we were going to grant FDA approval simply because there are promising data, and there are just so few options that those patients have otherwise. And so the time frame can vary, but to answer your question in short, it's often many years, 5 to 10 years often. Now, when it comes to the advantages for patients to have clinical trial access, it's a great question. And because we obviously have, obviously therapeutic paradigms for many different cancers, we have therapies we can often offer. But essentially, clinical trials are helpful because, oftentimes, especially when we run out of options, when we kind of run through all the different lines of therapy, clinical trials are often done to see, in many cases, can we offer any new treatments once someone has failed everything? And so we often run into that situation here where patients may have gone through 3, 4, 5 lines of treatment, and now they're still doing well, but we have to find something we can offer them. And so having access to clinical trials allows us to be able to refer them to UCSF, for example, where they can then receive that therapy and hopefully get a response from them in that situation.
Thank you.
Anyone else? Well, if not, we'll thank you again, and we'll let you go. Thank you for your presentation tonight.
Great. Thank you again for your time. Really appreciate it.
Thank you. Very good. We will move on with our reports. Dr. Hyder, I believe you're on. You there? I know he's on. Oh, he was on a minute ago. Did he drop? Did we lose him?
He's in the meeting, but he's not responding to the request.
Oh, yeah.
Why don't we go on to Debbie, and then we can come back to Dr.
All right.
Ryder.
All right. I'm happy to skip to Debbie. for their Service League report. Thank you.
Hi, good evening, the members of District Board, and greetings from the volunteers. In the month of September, we had 174 Service League volunteers, and they contributed 1,775 hours to the hospital. We also hosted another orientation in September, and we attracted 4 adults, 8 college, and 4 high school volunteers. One area I'd like to highlight this month is the Mending Hearts. This program provides visitation and information support for patients recovering from a cardiac event. The volunteers work in the telemetry unit and cardiac rehab. They organize activities for heart patients. They also give them a lot of information on nutrition, diet. They work really well with these patients, especially since it comes from nowhere and they're caught off guard and don't know what happened. They also do like walking activities around Lake Elizabeth. They're trained by Mending Hearts organization, but they're a Service League volunteer. They have to become a volunteer through the Service League for Washington Hospital. They've been active with the hospital since January 2022, and the volunteers have served 218 heart patients in either in person or by phone or email. So they really have helped out a lot with that area. Finally, on a sad note, one of our longtime volunteers, Charlie Rosaria, passed away peacefully last week. He volunteered from 1999 to 2019. He was a face in the lobby. He always had a smile and a greeting. He was a very, very sweet man. He passed away in his sleep, and he was 99 years old. And that's the Service League's report for the month. Do we have any questions?
Thank you, Debbie. Yes,
No problem.
Charlie was a very special man. He volunteered into his 90s, and when he first started volunteering, he says, I'm going to volunteer and I'm never going to a luncheon. I'm never going to a meeting. I just want to volunteer. But everybody knew him, and he was a great asset to our patients and our staff. They all knew him and loved him. So thank you very much. And Mending Hearts, it's nice to hear that they're back. I mean, they've been with the hospital for a long time, and they're great navigators because many of them have been through what our patients are going through at the moment. So they're great partners to come alongside. So thank you, Debbie.
Sure.
Thank you. Next, our lean report. Kimberly, I'll let you introduce our presenters for lean.
All right. Did Dr. Hyder get?
He's not responding.
Oh, okay. All right. No, it's all right. No, I will do the lean report. So
Keep moving until we hear from him. Okay.
Yes.
Just let me know.
Yes, I will. So I do want to introduce 2 other members of the oncology program, and one is relatively new, and her name is Tammy Tyson. And Tammy Tyson is the new Director of Oncology who joined the team in July of this year. She moved to Fremont from Grand Rapids, Michigan. Tammy spent the last 22 years at Helen DeVoe Children's Hospital, a member of Spectrum Health, where she managed the outpatient pediatric hematology oncology bone marrow transplant clinic, the pediatric infusion center, and the pediatric pain and palliative care program. She obtained her Bachelor of Science in Nursing degree from Grand Valley State University in 1999, and her Master's in Business Administration with a healthcare emphasis in 2017. Tammy is a certified pediatric oncology nurse and will pursue certification in adult oncology. She has a passion for oncology nursing and is honored to join the UCSF Washington Cancer Center team here at Washington Hospital. So welcome, Tammy. And then I am going to also introduce Sherry Kellen. Many of you may know Sherry. She has worked at Washington Hospital for 29 years. starting as a certified nurse assistant, a unit clerk, and a transporter before pursuing her nursing degree. She became a registered nurse in 1999, graduating from Maloney College in Fremont with an associate degree in nursing. She obtained her postgraduate degree at the University of San Francisco, and in 2017 graduated with a master's degree in clinical nurse leadership. Yes. She developed a passion for oncology nursing while working in the inpatient oncology unit, became certified in oncology nursing, and transitioned to the outpatient infusion center when it opened in 2011. In 2019, she transitioned into the role of nurse manager of the infusion center. So it's my pleasure to introduce both Tammy and Sherry, and they are going to talk about improving the patient experience through collaboration in the infusion center.
Thank you so much, Kimberly, and thank you to you, the ladies and gentlemen of the board. I think Sherry is going to pull up our presentation PowerPoint, but we both just wanted to thank you so much for having us, and we wanted to share some information with you about how we in the Infusion Center work to improve patient experience through collaboration. As most of you may know, the Infusion Center is located in Washington West, right next to the hospital. Sherry, do you want to do the next slide, please? It is comprised of 8 infusion chairs, 1 procedure room, and 2 quick treatment rooms. The quick treatment rooms are used for hydration, injections, blood draws, and central line care. We offer several different types of treatments that include chemotherapy, immunotherapy, which you heard a little bit about from Dr. Sharman, and supportive care medications. Those include antibiotics, blood, hydration, as well as other therapeutics. We are very excited for the new Cancer Center to open to better accommodate our patients and serve our growing census. We currently treat about 5,500 patients a year, and because we anticipate a 7% growth over the next year, we will be extending our hours of operation within the next couple of months. Our current hours of operation are Monday through Friday from 8 a.m. to 5 p.m., but we will soon offer services until 7 p.m. 4 days a week. The team is absolutely incredible, and actually the reason I did make the move to the Fremont area. This team takes great pride in caring for oncology patients, as well as other patients. The nurses are oncology trained, and over 60% of them are actually certified in oncology. The commitment to oncology certification is beneficial to everyone. It gives nurses a greater understanding of oncology care and disease process, which then gives them greater confidence to recognize just subtle changes that happen with our patients. And when they can detect those subtle changes, they can get escalated attention when needed. The expertise leads to better patient care and better patient experience. The joint venture that you also heard a little bit about from Dr. Sharman is another initiative that will bring great benefit and continue to bring great benefit to our patients and the members of our community. Access to academic level care and research opportunities allow our patients to receive this advanced cancer care close to home and in Washington Hospital, which is the hospital they know and trust. UCSF is an excellent partner and equally committed to exceptional cancer care. Could you do the next slide, please, Sherry? The impetus for our project was to improve the quality of life for cancer survivors through collaboration with rehab partners via our survivorship program. The survivorship program started in 2020 and is still in the early phases of development. The focus of our multidisciplinary team is to work together to meet the needs of cancer survivors. There's collaboration across many, many departments within Washington Hospital. The rehab department, physical therapy, occupational therapy, speech therapy, radiation oncology, the cancer center practice nurses, the infusion nurses, the medical oncology physicians, our social worker, and even our tumor board manager. I would like to now turn the presentation over to Sherry Callan to talk about the project goals and the lean interventions implemented to meet those goals. Through collaboration with the rehab experts, we developed a goal to establish a process to assess patients' physical function and intervene as needed through a referral to the appropriate rehab service. Sherry?
Thank you, Tammy. Thank you so much. Yeah, so as Tammy was saying, we met with our survivorship team, and we were really passionate about improving the lives of our cancer survivors. And as Dr. Sharman was explaining, many of them struggle with side effects either related to the chemotherapy or some of our treatments, or even the cancer itself. And rehab is a known evidence-based intervention that can help and improve those side effects and improve their survivorship. And so we really wanted to create an assessment process where we were assessing unmet needs and these types of side effects and provide referrals. So we wanted to partner with our rehab experts and align our goals with the strategic initiatives of the organization, along with operational priorities of our patient care services to improve patient experience. And so we wanted to move our patient experience from the category of staff working together to care for you from 91.67% to for quarter two ending in fiscal year 21 to greater than 96% quarter one fiscal year 23. And so some of our objectives were, again, to partner with our rehab department to improve the quality of life for our cancer survivors using an evidence-based functional assessment tool. And that tool was obtained by our rehab experts. They brought the tool to several meetings. One was our survivorship team meeting, cancer committee, and then we also asked our frontline staff to look at it, to even go over it with a couple patients and give their feedback, and then it was brought back and then redefined and approved through the cancer committee and through the survivorship team. And then we also definitely wanted to identify if there was any unmet needs that we could mitigate and improve upon, and then provide referrals to the different specific rehab departments as appropriate. One of the things that was really important and a high priority objective was to empower the patient and family through education, and then to transition them through our continuum of care to get to their highest level of wellness. And through our survivorship team, including the medical directors, the nurses, social worker, and our nutrition, all of those team members in survivorship, we came up with an inclusion criteria. We were going to do this assessment with patients that were completing chemotherapy treatment, patients that were completing radiation treatment, and then patients that won't be completing treatment, but that have metastatic disease, because they are survivors too. And we were going to do this assessment every 3 months to see how they were doing, if they were progressing, or if they still needed potential referrals. And so this is what our evidence-based tool looks like. It's on paper, and we give these tools to the patients. And as you can see here, there's various things that are being asked to see how they're doing, whether they have any new pain, whether they have any swelling in their arms or their legs, whether they have weakness, are they dizzy, have they experienced any falls, are they able to get dressed, button their shirt, are they dropping things? Because sometimes certain chemotherapeutics can cause neuropathy, and we want to identify those kinds of side effects as well. Trouble speaking, swallowing, so that we can refer them to speech therapy. And so we go through all of this. If they answer yes to any of these questions, then there's a potential for a referral. We do ask the patient's permission. Do you want the referral? And then we also explain everything, like why are we asking these questions? Why are we doing these assessments? And how that rehab referral and those specialties, how will that improve their lives? So that's where the empowerment comes in and where the education comes in. And then we cut this off at the bottom here, and we give that to the patient to follow up with phone call to make sure that they get that appointment on the books for them. During our 3-month pilot program, this is the pilot, this is an ongoing process now, but during the pilot program, we screened 79 patients, 27 of them were referred to rehab, and 8 patients did decline. And then to date, we have over 170 now.
Wow.
And we are continuing to, that grows. So the way in which we kind of moved through this process, and we're continuing to move through it, is we integrated our lean methodologies. So we aligned our goals with the Washington Hospital strategic initiatives. We identified our success factors. Along the lines, we developed standard work, for example, work at the bedside for our nurses, our frontline team, to be able to, what they were going to educate the patient on and how that worked, standard work for the referral process and all of that. And then using visual controls at our huddles, where we bring our data to the team so that we're kind of monitoring that as we're going along. Are we making improvements? Where can we improve? Getting their feedback. Also using visual controls within our Epic system to identify who needed to be assessed and when, and then just tying that into the performance of our team and letting them know where we're at with our goals. And then this is the way we integrated the actual assessment into our Epic, which is our electronic medical record. So we have in the nursing flow sheets the actual assessment. So once the patient fills out that paperwork, or the nurse helps the patient fills out the paperwork, we implement it into Epic so that we're collecting this information and we can look at reports later and referrals. And then we added it to the oncology synopsis, which is where we look at all things related to oncology data on patients. And this allows the charge nurse who's identifying patients that needed to be assessed when they were assessed last. So it just improved efficiency. And we, of course, looked at all of our success factors. We knew we needed to make a criteria for inclusion to be able to do the assessments, of course, our evidence-based tool, and then communication along the lines, getting nurse and practice nurse buy-in, patient participation, education was really important, and then collaborating between the departments was also key. Helped us be successful. And here's our data, and this is really kind of what we were looking at. Could we collaborate along the lines with rehab and practice nurses from radiation and the infusion center? Could we help the patient experience improve in this category? And we wanted to get above the 96% range. And as you can see, we were doing that, and we are sustaining it. And I just want to add, for the month of September, we had a number of, I think, 16 surveys, and we were at 100% for September. So we're really proud of that. So it shows, continuing to working together, the patients feel like we're doing a good job in that. And that's exactly what we want to do. One of our patients who has multiple myeloma gave us some feedback after she went to rehab, and we could actually see her improvement because she was in a wheelchair, and because of the treatments and because of the rehabilitation, she was able to now come in just using a walker, but way better strength, in all of her body. So she also stated that she felt so much better, that she has more strength, she's walking better and has more energy. And then her spirit even felt better. And she was so grateful to the therapy department. So some of our lessons that we learned: advocating for our patients is extremely important, empowering them, explaining the why of what we're doing. Data is essential. We were getting some Press Ganey information back from different departments, so we worked with them, and we're now getting infusion center data and comments related to the infusion center. So we know we're on track and we're getting accurate information. That was important. Partnering with our Epic team was very important to getting things into the system and making it more efficient. And we just know that it takes a village, and we, sharing successes and practicing gratitude at our team huddles, was really important, and just being, thankful for the work that was being done, and just sharing this presentation with our members too was important as well. And so our next steps, we want to keep redefining the process for plan, do, check, act methods for lean. We also plan to refer to social worker after the patients are done with treatment.
Wow.
We feel like that's going to help them in many ways. One way is that when you have cancer, as you know, and you're done with your treatments and you had all this support for so long, it can be scary and it can be very fearful. One, worried about the cancer coming back, and two, just not knowing where the support is, and so we want to make sure we are connecting them to the next steps, the next provider, mitigating any of those fears, and also just connecting them back into the resources within the organization or within the community, so that they get their needs met. And so we're working on that referral, and then we would like to collaborate with the palliative care. And of course, as Dr. Sharman and Tammy said, we're going to be extending our hours because we've had a lot of growth. And then our new cancer center is going to be a benefit to our community. And we would like to expand this particular program to the inpatient oncology. And this is our pictures of our teams: Infusion, the UCSF Cancer Center, and this is our radiation oncology team. And down here is our outpatient rehab partners. And that is our presentation. We thank you so much for having us and allowing us to share this presentation. Thank you guys so much. Any comments or questions? Happy to take too. Thanks.
Thank you, Sherry and Tammy. Any questions, comments from board members?
That's very exciting stuff. Very, very impressive. Thank you very, very much.
It's such great work, just beautiful work. Thank you so much.
Thank you.
I love that you said you want to get them to the highest level of wellness, because it's not just getting their infusion, getting them in, getting them out. It's going above and beyond. And I love that you all recognize that right now they're getting so much support and so much attention, but when it's over, you don't want them to feel unsupported and alone again. So that continuity of care, the collaboration, great work, great work. We appreciate you. Thank you so much. And welcome, Tammy. I'm so glad you're here.
Thank you so much. I'm very grateful to be here.
Good. We're excited for all the growth. Any other comments from the other board members before I let them go? All right, well, have a good evening. Thank you so much. Great. All right, Dr. Hyder,
Hi.
you ready for your medical
Good
staff
evening.
report?
Yes, I'm sorry you called my name. I missed it.
That's okay. You're more than welcome to go now. Thank you.
Thank you so much. Good evening to all. So our hospital physician census at this time, the staff number is anesthesiology is 29, family medicine is 43, the general medicine is 256, OB-GYN is 33, pediatrics is 57, and radiology is 33, and surgery is 66. So our active members are 338, administrative is 1, allied health is 38, ambulatory is 97, consulting 8, courtesy 25, leave of absence 6, provisional active at this time is 43, provisional AHP 11, provisional consulting is 2, provisional courtesy is 11, and relinquishment is 1. The grand total is 581.
581.
Yeah. The other thing is the hospital census continue to be high, and the administration as well as Larry from our CNO, they are putting a lot of hard work to make it smooth, and the physicians have been cooperating, so early discharges, so that the census are in control. The other thing is COVID is obviously under control, and the Stanford has already, they have no more they required any for procedures or anything, any COVID test or even for their employees. They're not asking for the, so there has been a good news in that, definitely. And but we are going to wait for whatever the Department of Health recommend. This is my report.
Very good. Thank you, Dr. Hyder.
Thank you.
Well, next up, we have a quality report from the SDN. Kimberly, I'll have you do the introductions, please.
All right, thank you, Madam President. Now we're going to shift to another important partnership that we have, and that's with UCSF, our special care nursery. And this evening we have to have Dr. James McGuire here, and he is the medical director of the special care nursery at Washington Hospital, where he practices neonatology. He is also a professor of pediatrics at the University of California, San Francisco, and he practices and teaches at the UCSF Medical Center at Mission Bay. He received his undergraduate degree from Harvard, his medical degree from the University of California, San Diego, and a master in public health degree from UCLA, where he has also completed a residency in pediatrics and a fellowship in neonatology. His work interests include team harmony and collaboration. Dr. McGuire is fond of the Bay Area, having grown up here, and currently lives in Fremont with his wife and 2 children. So, welcome, Dr. McGuire. He is here with us in the boardroom, and I know Shri can turn the camera so that you can see him. Great. Yes.
Okay.
Should I be closer, or can you guys hear me from here?
Oh,
great.
Yeah.
Okay. Thank you. Hello, everyone, board members and all. And yeah, thank you for having me here to give the annual report regarding the special care nursery. It's exciting to talk about what's coming down the road. Next slide, please. Yeah, so this is a partnership with UCSF that started 8.5 years ago now. So UCSF started providing physician staffing in the special care nursery with neonatologists. And so the neonatologists and the pediatric hospitalists collaborate and work alongside Washington Hospital nursing and ancillary staff, and actually also importantly our volunteers, I was really grateful to hear the report from the volunteer services and many others. Services include stabilization of the newborns, respiratory support including ventilatory support until we typically have to transfer our babies on ventilators, and then initiation of therapeutic hypothermia, which is cold treatment, intravenous fluids, medications, nasogastric feedings. We use incubators, warmers, and monitoring of the baby's heart rates and breathing status. And I want to give a shout out to our new leadership, which is Stacy Davis, who took on added the role of SDN manager to her plate earlier this year. And we're really happy to have her on board. Next slide. So special care nursery census has varied over the years. It's sort of somewhat proportionate to the live births, and the darker green is 2021 and the lighter green is 2020. And so the live births were about the same in those 2 years, and the number of babies did vary. We had more babies come into the special care nursery in 2020 than in 2021, and our census sort of was related to that. And so our census was average daily was 3.2 in 2020 and then 2.56 in 2021. And why that goes up and down, it's a little bit random. It depends on the patient population. If the more mothers show up and deliver prematurely, then we're going to have more babies for the special care nursery. And if more mothers don't deliver prematurely, then we won't have as many babies. And so that's why it's not a direct proportion to the live births. For this year, actually, we're averaging probably just a little over 3, looking at our numbers through September 30th, 2022. And so we're going to continue to try to make efforts that if there are premature babies or babies who need special care, nursery care, that they'll get care here. And in the ways we make efforts to do that is we work closely with Dr. Jackie Chu, who's our perinatologist, also a UCSF faculty member, and she has a TDC clinic on the Washington campus. And then we also collaborate and work well with the other OBs, for example, with PAMF and so forth, to try to encourage them to deliver babies here that if they need special neonatal intensive care unit care, that they'll get it here at Washington, so that the babies will and the families will be able to stay in the community that they live in and in the region. Next slide, please. Quality and strategic initiatives. So the initiatives, we have a SCN Clinical Operations Committee, and we discuss initiatives with the this multidisciplinary committee that has social workers, nurses, doctors, pediatric hospitalists, and so forth, so that we can make sure everybody on the team feels that the initiative is making sense. One that really made sense was the infant-driven feeding. And this is an approach that helps the babies in terms of feeding better, getting out of the hospital potentially sooner, and doing well long-term with feeding. We'll talk about that in a second. The other one was to enhance patient safety outcomes. We continue to do simulation training, which has been shown nationally to help out with outcomes, and we'll talk a little bit about that. Next slide, please. So infant-driven feeding is really a focus on a cue-based feeding. So it used to be that back years and years ago that feedings with babies would be, it was trying to feed the baby even if the baby wasn't truly interested, and that had problems with aversive behavior down the road, and problems that we could create in the special care nursery. Now there's been a new process that's been identified, and we rolled it out in 2022, which is to allow infants to show when they want to eat and help them with the duration and volume of the feeding. And so with the premature babies who are, when they're really premature, they're not interested in eating, we use a cue-based feeding as they become closer to their due date to let them drive the feeding. And this results in earlier transition to oral feedings in the older approach, decreased length of stay, reduces the aversive feeding behaviors, and it supports the baby's neurobehavioral maturity, and this has really been great for the babies. Next slide. This has been a national trend to use this new approach. The hospital supported it by purchasing a teaching program. The nurses do the feedings, and so they increase their knowledge of infant-driven feeding by taking a survey, and that survey was done prior to the education and after the education. As you can see, our scores went up from 65% to 76%, and with this knowledge and this increased knowledge of how to feed these babies well, things have gone well, and we've been checking in regularly, including this week, with the members of our infant-driven feeding task force. Thank you. The other one was the mock code simulation, and as I mentioned, this has been something that's nationally going on to try to improve outcomes by having regular training. And so we at Washington Hospital don't have a lot of high-risk deliveries and don't have a lot of neonatal codes, which in some ways is good, but in some ways means that we're not we don't have those occurrences happen frequently, so that we can be as ready as we like. So it requires simulation to enable us to be ready and to improve communication, improve confidence in those skills, because we're having those low volume of codes and these really premature babies born, extremely low birth weight. So the simulation training is conducted by the Special Care Nursery Pediatrics Multidisciplinary Simulation Team. We use high-fidelity mannequins, and we have a team led by Dr. Jess Alsofrom, and as a neonatologist, and other members of the team that collaborate to make our team ready, so that when we have these high-risk deliveries, we're ready. Next slide. And we do follow some metrics in the special care nursery. One of them is because we have central lines, we keep track of whether we have any central line associated bloodstream infections. We're very happy that we had none. Obviously, we don't have a lot of central line days, but that's still, we're very pleased that we continue to have meticulous care of our central lines by our stellar nurses to make sure that we are doing the very best we can in that regard. Next slide. Updating policies and procedures. So we work, the new policies that we came out was one, the infant-driven feeding, which I sort of already talked about. And then the other one was the peripherally inserted central catheters for neonates, and this is, again, a central line. And we wanted to have a policy that was tailored just for our population and that made sense, and that helped the nurses know how they could take care of these catheters well, and so that we could minimize, again, the likelihood of the central line-associated bloodstream infections. Thanks. Education and professional development. So we continue to do this on a sort of regular basis of case studies with the nurses, the pediatric hospitalists, and the neonatologists from Washington Hospital Healthcare System. We also have UCSF, which supports both all the staff and the nurses. So they have an outreach courses for the nursing staff on neonatal nursing care. So the outreach team for UCSF sends us skill labs for procedures and stabilization for critically ill neonates. And then we also have UCSF faculty with neonatologists and perinatologists who come in and give another perspective and review cases and care and interesting situations that the obstetricians and neonatologists and pediatric hospitalists and nurses want to discuss. And then we also have the Association of Women's Health, Obstetric and Neonatal Nurses training, which is also helping support our nursing staff. Next slide. Patient experience. One of the challenges with our data here is that we have small numbers, and so sometimes our numbers are really good, and sometimes they're lower, and we are, as you can see, sometimes we range between like 82 to 100%, and we like sort of more consistency. We're really glad that with more stable with our leadership team on the second floor, nursing leadership, that we're hoping to sort of focus on these things a little bit more. The nurses, really are very good at friendliness and courtesy and keeping the parents informed. But I think that if we have more numbers and a little bit more attention to that, we'll probably have more consistency and higher numbers on average. Next slide. So our next steps are exciting. We're really looking forward to having an educator or clinical nurse specialist for the special care nursery. This will really help with moving forward on things and keeping policies and procedures appropriate and supporting the team. Then the other thing is we're very excited to be looking forward to our level 3 neonatal intensive care unit. This was something part of the master plan that Washington Township has had for a while, Washington Hospital. And so planning and designing and preparing is something we're starting to work on in conjunction, working with UCSF and working with administration and so forth to make sure that we get the unit that will then enable more babies to stay at Washington Hospital and more parents not having to travel outside the Washington Township to get care for their very premature babies, because we would be hopeful to keep the vast majority of those very premature babies at Washington Hospital. We're also hoping our plan is to resume the annual SCM reunion, as Dr. Hyder mentioned, with hopefully COVID becoming less of an issue than the reunion, which has been, we've not had in the last 3 years because of the pandemic. We're hoping to get that restarted in 2023. These are photos from our last one, where of course the theme was cowboy, and we're hoping to have another reunion with a lot of happy children, and hope that will come together in 2023. Next slide. I think that's the last slide. Yeah. Thank you. Any questions from the board? Anyone else?
Yeah, James.
Great.
Yeah,
Go ahead.
James, great presentation as always. What is the average length of stay for some of these babies? Do you know?
Yeah, I think it's around about 5 days. Some of them will be there for 2 to 3 days, and some will be there for 2 weeks, or longer even. But probably 5 to 7 days is off the top of my head. I didn't bring that statistic right with me this time.
And these numbers also include babies who are admitted for phototherapy and all that.
Well, actually, most of the babies with phototherapy stay with the mothers. That's been really something that's been great in terms of keeping babies with moms. And so the pediatricians, pediatric hospitalists will typically have the baby receive phototherapy in the mom's room. We have some babies admitted for phototherapy, but it's rare, maybe like a handful a year.
Great. Thanks.
You're welcome. Any other questions?
Thank you, Dr. James. Always
You're
good to
welcome.
see you. Great to hear all things that are going on. It's a wonderful unit.
See you, Debbie.
Great. Well, thank you very much. Have a good evening.
You too.
All right. Thank you. So next up, our finance report, Chris Henry.
Okay, well, while we get this up, tonight we will be looking at Washington Hospital's operational and financial results for August. Thank you, Shri. And we'll start with our acute inpatient statistics. Our inpatient average daily census for August came in one below budget at 146.9. When we add in our outpatient observation days, and again, these are outpatients that are in a bed and getting similar services as our inpatients, we come up with a combined average daily census that was 1.4 below budget at 157.1. Admissions for the month were 42 higher than budget at 850, and our patient days for August came in at 4,553. That's 32 below budget. Outpatient observation equivalent days for the month came in at 317. We had budgeted 329 for August. And our average length of stay for patients discharged during the month came in higher than budget at 5.94. We'd expected 5.67. If you recall, in Kimberly's report last month, we did have several patients with very long lengths of stay discharged in August, and that's what drove that up. Moving into utilization, the case mix index for the month, which is our indication of the severity of the patients we saw in August, came in at 1.6. We had budgeted at 1.618. Deliveries for the month were 12 above budget at 131. We had 400 surgical cases in the month. That's 24 higher than the budget of 376. Cath lab cases, however, came in below budget at 193. We had expected 215 in August. Outpatient visits were 296 higher than budget at 8,200. And the emergency room, again, continued to be very busy with 4,761 visits. That's 139 higher than the budget of 4,622. Quickly looking at the activity in the OR and the cath lab. Again, you can see the majority of the favorable variance in the OR was coming from our joint replacement cases. They were 16 higher than budget. And our other surgical cases, which includes everything except what you see above, were 14 higher than budget at 188. We did have unfavorable variances in our neurosurgical cases and cardiac cases in the month. In the cath lab, again, overall a variance of unfavorable variance of 22 cases for the month. The majority of those coming from non-vascular interventional radiology and our cardiac procedures. Neurointerventional radiology was also 3 below budget. Those were offset by peripheral vascular cases that were 7 higher than the budget in the month. Looking at productivity, our productive FTEs for the month were 12.4 lower than the budget at 1,361.7. We had 217.3 non-productive FTEs, which was 35.9 higher than the budget. That includes 20.6 FTEs that are related to the special COVID sick leave that the state has required. And again, those affect those FTEs because those are not vested benefits and they're not accrued. So we end the month with total FTEs that were 23.5 higher than the budget at 1,579. Our full-time equivalents per adjusted occupied bed, however, came in pretty close to budget, just a little bit lower at 6.19. We had budgeted at 6.28. Moving into financials, and first we'll look at our Governmental Accounting Standards Board presentation. This is the presentation we're required to use for our audited financials. Total patient revenue for the month came in very close to budget, $259,000 higher than budget, and $195,967,000. Our deductions from revenue came in a little bit higher than budget as well at 77.19%. We had expected 77.04% of charges. Looking at the details here, our contractual allowance, which is the allowance we make for patients that are covered by insurance, came in $1,154,000 higher than the budget at $148,200,000 or 75.62% of the revenue. Really, the payer mix there, while it appeared to be favorable, we did have lower government and higher PPO in the month. But within that PPO bucket, patients that were covered by insurances purchased from Covered California, the health insurance exchange, was higher than we had expected in the budget and higher than we've seen in quite some time at 2.1% of gross revenue. We have generally see that at about 1.3%. So that drove our contractuals a little bit higher than we anticipated. Our provision for bad debt and charity came in lower than budget by $656,000 at $3,070,000 for the month. So again, our total deductions from revenue for the month came in almost $500,000 higher than budget at $151,270,000. So we ended the month with net operating revenue at just $259,000 higher than budget at $45,685,000. That number includes, by the way, about a $500,000 rebate we received in relation to our employee drug benefits from Optum. Operating expenses for the month came in almost $1.1 million higher than budget at $43,565,000. Really, three main drivers driving that variance. Our salaries and wages came in $794,000 higher than budget. $480,000 of that was related to that special COVID sick leave. The rest was came about in overtime and double time. You know, again, with the tight labor market, we're having to fill in with overtime and double time. Benefits for the month were higher than budget by $134,000, largely driven by our healthcare claims. And supplies were $378,000 higher than budget. About half of that driven by our higher prosthesis costs in the month, and the other half driven in several areas with variances lower than $50,000, including our drug costs, our surgical supplies, our disposable surgical apparel, and cardiovascular and neuro supplies. Pro fees for the month, pro fees and purchase services came in lower than budget. They offset those unfavorable variances by $95,000, and our insurance, utilities, and other expenses came in lower by $140,000. So we ended the month with operating income about $812,000 lower than budget at $2,120,000. Non-operating, we actually incurred a non-operating loss for the month of $1,883,000, largely driven by an unrealized loss on our investments of $1,007,000. So we ended the month from a GASB perspective with net income for the month of $237,000. We had expected about $2.8 million, so that unrealized loss really hurt us. Moving into our Financial Accounting Standards Board presentation, and as you all know, this is a representation of how the financial markets might look at those financials. First thing we do is we reclassify $587,000 in revenue bond interest out of our non-operating area up into operating expenses. FASB disagrees with where those live in the financials with GASB. And we end with that adjustment with operating expenses just under $1.2 million higher than budget at $44,152,000, and operating income from a FASB perspective of $1,533,000 against a budget of $2,438,000. We then move to our non-operating section and we remove our general obligation bond interest expense of about $1.25 million. The tax revenue that supports the debt service on those bonds also gets removed. That's about $1.52 million. And we remove that unrealized loss on our investments. FASB doesn't recognize any of those. So we end up with non-operating income of $136,000 against a budget of $161,000, and a total bottom line just under $1.7 million from a FASB perspective against a budget of $2.6 million. Looking at our earnings before interest, taxes, depreciation, and amortization, this is a presentation that gives us an idea of how much cash the operations are producing. First thing we do is we remove depreciation expense from our operating expenses, because depreciation expense is a non-cash accounting entry that recognizes the expense of cash flow that has previously occurred on capital assets. And we end up with EBITDA of little over $5.7 million. And then next we move down into the non-operating section and we separate out our interest expense, and we end up with other non-operating loss of about $45,000. So in total, Washington Hospital's operating and non-operating activities provided about $5.7 million for the purpose of debt service, capital expenditures, and program development for future needs. So are there any questions on August's financials? Okay.
All right, do you want me to go on to September's?
Go for it. Thank you.
Okay. All right, I'd like to present the preliminary numbers for September 2022. Beginning with gross revenue of $189 million for September was below budget by $5.6 million or 2.9%, and was below September 2021 by $6.3 million. Inpatient gross revenue of $112.9 million was below budget by $2 million and $6 million below September of 2021. As you can see, this was primarily driven by the cath lab charges being below budget. Our outpatient gross revenue of $76.2 million was below budget by $3.6 million and $313,000 below September of 2021. And again, the unfavorable revenue variance was driven by lower cath lab and also observation charges. In September, there were 41 COVID-19 discharges, representing about 5% of total discharges. This was a decrease of 40 cases from the prior month and was 25 less than September of 2021 at 66 discharges. Going on to the key statistics, the average length of stay of 5.45 was below the budget of 5.62 by 0.17 or 3%. This was also lower than the September 2021 average length of stay of 5.78. There were 13 discharges with length of stay greater than 30 days, ranging from 31 to 93. And excluding these outliers, the average length of stay was 4.86. So we're not seeing as long at this point of the length of stay outside of the 30 days. Still in-house, though, at the end of the month, we have 6 patients with length of stay over 30 days, and those range from 40 to 85. Moving on to our outpatient observation days at 242 was below the budget of 357 by 115 days, and 100 days below September of 2021. We have implemented a new position, the new portal of entry program, and it's resulting in decisions being made regarding patient placement on a more timely basis, which is helping to make sure that the patient gets in the appropriate level of care at the beginning of their stay, and it's reducing the length of stay for OBS patients also that are staying in-house. Our inpatient average daily census of 159.1 was above the budget of 152.9 by 6.2 and above September of 2021 average daily census of 154.9. So the combined average daily census of 167.2 was above the budget of 164.8 by 2.4 and 0.9 above the September 2021 average daily census. The combined average daily census, as mentioned before, includes both outpatient observation equivalent days. Looking at our admissions of 850 were above budget of 816 by 34 or 4.2%. September 2022 admissions were 46 or 5.7% above September of 2021. Our patient days of 4,774 were above the budget by 188 or 4.1%, and were 126 days or 2.7% above September of 2021. But what we saw was ICU and IMC utilization were lower than budget by 7%. Looking at our surgical trend, total surgeries in September of 370 were above budget by 9. Surgeries were 14 below September of 2021. Our inpatient surgeries at 145 were 12 or 9% above budget and 4 above September of 2021. And outpatient surgeries at 225 were 3 below budget and 18 below September of 2021. I just want to remind the board that we did, in terms of the Peninsula Surgery Center, we did receive our Medicare certification number on Tuesday, September 13th, and we did start billing Medicare on Monday, October 3rd, 2022. And we'll continue we are working on the process of contracting and credentialing the medical staff with commercial insurance companies, and we will continue to see migration from the hospital side to the Peninsula Surgery Center. Looking at our surgical activity, broken down, our joint replacement surgical cases were above budget by 5 or 3.2%, but were 9 below September of 2021. Joint replacement cases are expected to decrease from prior year, as I mentioned, because the surgery center is starting to ramp up operations. Our neurosurgical cases were above budget by 1 or 3.8% and were 10 above September of 2021. Cardiac surgical cases were below budget by 3 or 23.1% and were 3 below September of 2021. All other surgical cases combined were above budget by 6 or 3.6%, but 12 below September of 2021. Moving on to our cath lab, we continue to have some challenges in our cath lab volume. Cath lab cases for September at 144 were 83 or 36.6% below the budget of 227 and 75 below September of 2021. Our cath lab inpatient cases at 64 were 58 or 47.5% below budget of 122 and 59 below September of 2021. Our outpatient cath lab cases were at 80, which were 25 or 23.8% below budget of 105 and 16 below September of 2021. I do want to say we had one of our very busy IR physicians was out for 2 weeks, and then we also had a couple of our busy cardiologists were also out, or saw fewer patients than normal during this period of time. So we are continuing to watch it, but we've had a number of physicians that have been slower this last month, say the last 2 months. In terms of cath lab activity, cardiac cases were below budget by 31 or 29.5%, and 9 below September of 2021. Non-vascular interventional radiology cases were below budget by 26 or 39.4%, and 26 below September of 2021. Peripheral vascular cases were below budget by 26 or 53.1%, and 39 below September of 2021. Our neuro cases were right on budget at 7, but 1 below September of 2021. Moving on to deliveries. Deliveries for September of 114 were below budget by 16 or 12.3%, and 27 below September of 2021. As you can see from the graph, we continue to see some volatility in our numbers in terms of our deliveries month by month. Moving on to our non-ER outpatient trend, non-emergency outpatient visits of 8,644 were below budget by 385 or 4.3%, and below September of 2021 by 315. This was driven mainly by lab visits, which were below budget by 236 or 6%, and 258 below September of 2021. This is mainly due to the reduction in pre-procedure testing being down compared to the prior month due to lower, as we know, vascular, OBGYN, and interventional radiology cases. Also, the lymphedema clinic visits were below budget by 119 and 112 below September of 2021. We did have one of our therapists that was out for over around 3 weeks at that unit. Moving on to emergency room visits, they were at 4,737. They were above budget by 75 or 1.6%, and 336 above the prior year. So emergency room continues to be busy. Moving on to gross revenue, our surgical cases were above budget by 9 cases or 2.5%, increasing revenue by $1.1 million or 3.1%. Room and board revenue was below budget by 119 or 0.3%. There were higher patient days in September than budgeted, but revenue is below budget due to lower utilization of ICU and IMC beds, and observation days were also lower. Our deliveries were below budget by 16 or 12.3%, driving revenue below budget by $281,000 or 7.7%. Emergency visits were above budget by 75 or 1.6%. However, patient acuity was lower than expected. Emergency room revenue was below budget by $283,000 or 2.3%. And lastly, cath lab cases, as we know, were below budget by 83 or 36.6%, and revenue was $5.2 million or 36.8% lower than budget. Lastly, ancillary services were below budget by $752,000 or 0.8% due to lower inpatient activity. Looking at our preliminary payer mix, our government-sponsored patient revenue made up 71.3% of total gross revenue. This is lower than the budget of 71.5% and lower than the prior year's percentage of 71.8%. Our HMO was 2.3% of gross revenue, below the budget of 2.6%, but higher than the prior percentage of 2.1% of gross revenue. PPO was 25% of gross revenue, which was above the budget of 24.3%, which was good, but lower than the prior year's percentage of 25.5%. And then lastly, our private pay was 1.4% of gross revenue, below the budget of 1.6%, and higher than the prior percentage of 0.6% of gross revenue. Looking at our productivity indicators, our productive FTEs were below budget by 16.4 or 1.2% at 1,390.3. Our non-productive FTEs were above budget by 22.5 or 11.4% at 219.1. I do want to say our COVID-19 sick leave non-productive FTEs were 9.96 of this 22.5. I also want to just note that the supplemental COVID-19 sick leave program was extended by the governor through the end of the calendar year of 2022. Our total FTEs of 1,609.4 were above budget by 6.1 or 0.4%. Our productive FTEs per adjusted occupied bed of 5.22 was lower than the budget of 5.43 by 3.9% and lower than the prior year of 5.24 by 0.4%. Total FTEs per adjusted occupied bed of 6.04 was lower than the budget of 6.19 by 2.4%, but higher than the prior year of 6.01 by 0.5%. So overall, our productivity indicators were below budget. Then moving on to our preliminary outpatient statistics. Witness clinics were below budget in September by 1,405 or 8% at 16,118 and 1,256 visits below September of 2021. We did have a number of providers, physicians that were out during the month of September, and primarily the Warm Springs and State Street primary care clinics were down 640 visits, and our specialty service clinics were down about 1,088 visits. So again, a number of physicians that were out during that month. Looking at DevCo outpatient visits of 2,206 were below budget by 82 or 3.6% for September and 38 below September of 2021. Looking more specifically, our Washington Outpatient Rehab Center was below budget by 193 or 13.9%. And during September, we did have 2 open positions for therapists. At this time, we did fill one of them. A new full-time therapist started at the end of September. So we're still recruiting for another one, but we do have one that just started. Our radiation oncology treatments were above budget by 71 or 21.5%. Our surgery center visits were above budget by 1 or 0.2%. Our Peninsula Surgery Center visits were below budget by 18 or 60%. Just as mentioned before, we're slowly ramping up. And then Ohlone College Student Health Center visits were above budget by 57 or 475%. So we're seeing definitely more visits through Ohlone College as more of the students come back on site. Looking at key financial statistics, days cash on hand for September ended at 154 days, a decrease of 8 days from last month. This was driven by a number of different things happening. First of all, we did have an increase in funding because Witness had the Medical Foundation had a 3-pay period payroll. We also saw an increase in accounts payable and benefit expense payments for September. We also saw unrealized investment loss of $2.2 million Chris referred to in terms of the financials, and then quarterly pension and OPEB contribution payments of $2.9 million, which equated to 2 days. Our days in accounts receivable in September were 62.4. This is down 0.4 days from September and 5.9 days below September of 2021. And then lastly, there were $781,000 in charity care adjustments in September. Sorry, Chris. I had a hard time getting your name out.
It's okay.
Very good. Thank you. Any questions for Kimberly? All right. Announcements, Kimberly?
Yes, I do have a number of announcements. I'm going to start with Employee of the Month. And I'm pleased to announce that the Employee of the Month is Nasima Fayaz, the Medical Staff Coordinator. And then she quotes, "The medical staff office is the front door to patient care. That's the way Nasima Fayaz thinks of the work she and her coworkers do. Working to thoroughly review each physician as they join our medical staff, Nasima feels she is helping to ensure excellent patient care. She says, this is how we provide patient care without having a clinical presence." Nasima began working as a credentialist specialist at Washington Hospital in 2017. Her manager describes her as someone who can balance several projects at the same time while maintaining a high level of performance. In February, she was promoted to medical staff coordinator. The onboarding of physicians is typically a complex process that sometimes needs to be completed in a short period of time. Nasima must consider the needs of departments and the importance of documenting the education, certifications, and work experience of every physician seeking privileges. Originally from the Fiji Islands, Nasima arrived in the U.S. in 1988. Though she admits that life was challenging for her mother and siblings, they all have done well and remain close. Her desire to help others led her to working in the healthcare industry. She and her husband live in Hayward, where they have raised a daughter with the same principles of helping others. Nasima's hobbies include participating in Zumba classes with her daughter and gardening. Her desire to be part of the overall patient experience and her strong work ethic make Nasima the perfect choice for October Employee of the Month. Congratulations. All right, I'm just going to go over some of the events for the last month. I will say it's been a busy time. There were a number of events that Washington participated in. Starting on Tuesday, September 6th at 6:30, Dr. Dearborn Orthopedic Surgery presented Don't Let Hip Pain Win, Updates in Hip Replacement. It was on Facebook Live and YouTube. We had 166 community members participated in the live event, with 587 viewers accessing the content later on. On Wednesday, September 7th, Washington participated in Poly Step Out, hosted by the Ruggieri Senior Center in Union City. At the Wellness Fair, nurses administered free blood pressure and blood oxygen screenings to 40 community members. On Monday, September 12th at 12 p.m., Dr. Eldon Eichbaum, neurosurgeon, presented neck and back pain relief, cervical and lumbar disc replacement. On Facebook Live and YouTube, 196 community members participated in the event, with 764 viewers accessing the content later. On September 14th, Washington participated in Newark Community Days information fair along with a parade, and had many members were provided free blood pressure and blood oxygen screenings. On Wednesday, September 14th, Elisa Curry, coordinator of rehab clinical programs, and Christy Caracappa, health insurance information coordinator, presented information on fall prevention and recovery and health insurance enrollment to the residents of the Masonic Homes Retirement Community in Union City. We had 21 residents that attended. On Wednesday, September 21st, Larry Aseo, physical therapist, presented As You Age, Stay Fit, Stay Safe, also on Facebook Live and YouTube. 96 community members participated in the event, with 697 viewers accessing the content later on. On Saturday, September 24th, Washington participated in the HERS Breast Cancer Run, Walk, and Yoga at Quarry Lakes Regional Park in Fremont. 28 community members were provided free blood pressure and blood oxygen screenings, and 7 received free chair massages, and many people received, I will say, information on all of our services at this run walk. On Saturday, September 24th, Washington participated in the Mutt Strut hosted by the New Haven Schools Foundation. And then on Sunday, September 25th, Washington participated in the Disability Resource Festival hosted by the Fremont Human Services Agency at the Fremont Downtown Event Center. On Saturday, October 1st, Washington participated in the Science in the Park at Cal State East Bay, with over 200 community members receiving education from the stroke team and food and nutrition department. Also on October 1st, Washington hosted a tattoo removal clinic in partnership with Second Chance. 28 people were served during the event. On Sunday, October 2nd, Washington participated in the Arune Foundation Walkathon at Quarry Lakes. 25 community members were provided free blood pressure and blood oxygen screenings. On October 3rd, Elisa Curry, coordinator of rehab clinical programs, presented information on fall prevention and recovery to the residents of Koger Retirement Community in Fremont. 22 people attended. On October 6th, Dr. Stephen Portion-Kolab, Family Medicine, presented its flu season, Just Say No, on Facebook Live and YouTube. 102 community members participated in the event, with 570 viewers accessing the content later. On October 5th, J.B. Goodyear, Spiritual Care Coordinator, presented information on grief, loss, and self-care to the residents of Acacia Creek. 29 residents attended. And on October 8th, Washington participated in the Fremont PD Public Safety Fair at the Fremont Main Library. As you can see, it was a very busy time in September and October. Also in October, as of Thursday, October 6th, a total of 93,654 COVID vaccine doses have been administered to community members at our vaccination clinic. We've also been giving MPX vaccinations, and as of October 6th, a total of 32 MPX vaccinations have been administered. I also want to say that we've been doing many community flu vaccination clinics, and at this point, the Medical Foundation has provided 923 community flu vaccines in Fremont, Warm Springs, Union City, and Newark. So I know that's been very popular. Also, just want to talk about 2 awards that we recently received. The first is the National Accreditation Program for Breast Centers, a not-for-profit organization that recognizes breast centers providing high-quality care in the United States. And we were once again granted accreditation to Washington Hospital. And accreditation by the NAPBC is granted only to those centers that commit to providing the best possible care to patients with diseases of the breast. So we did that. And also, the Commission on Cancer, a quality program of the American College of Surgeons, has once again granted 3-year accreditation to the cancer program at Washington Hospital. To earn this accreditation, the cancer program must meet 34 quality standards and maintain a high level of excellence in the delivery of comprehensive patient-centered care. And I think that's definitely supported by 2 of the presentations that we heard this evening. Just a couple of our upcoming events. October 13th, tomorrow, we do have our 14th annual Think Pink event. It's a breast cancer awareness event from 5 to 7 p.m. On October 15th, we have the Maternal and Child Health Department is hosting a Wave of Light in the Rose Garden at Washington in recognition and loving memory of pregnancy and infant loss. On Sunday, October 16th, from 12 to 2, the Maternal and Child Health Department is hosting the Blue Dot Walk, and it's to help raise awareness for maternal mental health. Then on October 18th, Christy Caracappa, our Health Insurance Information Coordinator at 3:30, will present Medicare, What You Need to Know on Facebook Live and YouTube. And then 2 other, 2 more educational programs. One is October 25th. Dr. Jet Liu, orthopedic surgeon, will present information on common foot and ankle problems to the residents of Fremont Hills Retirement Community. And on Wednesday, November 2nd at 3:30, Dr. Jack Rose from Neurosurgery will present stroke awareness, risk factors, and prevention on Facebook Live and YouTube. Then lastly, our report from the Healthcare Foundation. We are Washington UCSF Cancer Center. As you know, we've have a capital campaign raising money to build out our cancer center. And since February, we now have documented $4.6 million in pledges to date. So as you know, we have our goal is a $10 million. And then on the foundation, as we all know, hosted the 36th annual Top Hat Gala on Saturday, October 8th at 6 p.m. At the tent at Washington West. And the funds raised will support the purchase of equipment and technology for the hospital's trauma center. We had over 325 individuals attended. I don't have the final fundraising goals yet since they are still counting at this time, so I'll have that information at our next meeting. All right, that concludes all of the events and everything that is happening or has happened over this last month or so. So thank you very much.
Thank you. Busy, busy month.
Yes.
Well, great. Well, as there's no need for a closed session this evening, there's no further discussion, we will adjourn and say thank you all for being here. Thank you for your hard work. Keep it up. Have a good evening.